All right, I'm sure you probably said QT interval. So a prolonged QT interval itself is something to monitor. Patients come in all the time to the ER and they have a prolonged QT and we just say, okay, we're not going to give them certain medications. If a patient is having the occasional palpitations, we are concerned about the development of dysrhythmias. We're concerned with the dysrhythmias that could potentially be deadly. And we know that quinidine has the black box warning of torsades de points. All right, class 1B, so we're still in the sodium channels. So these drugs are gonna act preferentially on ischemic myocardial tissues. What does ischemic mean? Lack of oxygen, absolutely. So lidocaine is gonna make it difficult for the ventricles to develop dysrhythmia. It kind of just puts a damper on the ventricles and says, hey, stop misbehaving. You can't create a dysrhythmia here. It makes it difficult for the ventricles. We only use this drug for ventricular dysrhythmias. With lidocaine, there are many different kind of dose formulations. You want to be really mindful that you're giving the correct medication. And then phenytoin, if you'll remember, is a drug that we gave for seizures. So that's pretty interesting. So we can give this for atrial and ventricular tachydysrhythmias. So anything that's weird, the top part of your heart is beating fast and incorrectly, and the bottom part of your heart is beating fast and incorrectly. And this would be in the case that it's caused by digitalis toxicity. Do we remember what digitalis is? That's digoxin, or if somebody has the long QT syndrome and has developed this. Okay, so class 1C, here we have flecainide and propenephone. So flecainide you may see with atrial fibrillation, but it shows overall that it's going to lead to increased rates of death, so providers are hesitant to use. I've never worked in the cardiac ICU, but I've never seen this given in the ER. And the propenephone, I've never seen that given either. We would use that for ventricular dysrhythmias. All right, we know all about this. Class 2, beta blockers. So we remember beta blockers are going to have a negative effect on the inotropic, chronotropic, and dromotropic. What is dromotropic? If you don't know, pause it, look it up. So dromotropic is the electrical activity. So this is actually going to decrease that transmission of impulses in the heart's conduction system. We use these for supraventricular and ventricular dysrhythmias. So we talked about atenolol, right? We know atenolol is non-selective. It's specifically going to work on beta-1 receptors. Esmolol is something we can use IV for tachydysrhythmias, and then metoprolol is in that class as well. Okay, class 3, this is something we have not talked about. So these class 3, they call them potassium channel blockers. These are used for dysrhythmias that are difficult to treat. So these are life-threatening ventricular tachycardia or fibrillation, atrial fibrillation, or flutter. So amiodarone, this drug down here, amiodarone is used with our ventricular deadly rhythms. So if somebody is having that, they're going to get amiodarone. That's the go-to American Cardiac Life Support go-to drug. So it's actually going to inhibit the ability to repolarize and make that resting refractory period longer. You cannot combine this with digoxin. It has a long half-life. All right, we talked about this too. Class 4, calcium channel blockers. Calcium channel blockers depress the phase 4 depolarization. They're going to reduce that AV node conduction, which is in the middle. We can use these for paroxysmal supraventricular tachycardia. I know these all sound just like crazy words to you guys, but with the calcium channel blocker, if somebody comes in, so atrial fibrillation is the upper portion of your heart fibrillating or quivering. So when you see patients with atrial fibrillation, they're not going to have a nice lub-dub. It's going to be this irregular pulse. And typically it's okay. Your biggest concern is that somebody would have a stroke from clotting. But typically with atrial fibrillation, their blood pressure is okay. They're perfusing well. Well, sometimes they'll go into something called atrial fibrillation with a rapid ventricular rate. So that upper portion of the heart is quivering and their ventricles are beating very, very fast. In this situation, because their heart is, these are typically not very healthy people and their heart's beating 140 times a minute and they typically don't feel very well. Our go-to drug in my ER is diltiazem. So that first drug. So every single person, I would say 95% of people are going to get diltiazem. The only time we would not give diltiazem or we would stop it is if their blood pressure is too low. Okay, so adenosine. This one is probably the coolest one to give. So adenosine we give to convert supraventricular tachycardia to sinus rhythm. Supraventricular tachycardia is just this very, very, very fast heart rate. It looks very, very, very fast. See it a lot in younger people. So to get it back to a normal sinus rhythm, when you see sinus rhythm, that is the normal lub-dub heart rate. That is the normal heart rate. So we have just, it's typically somebody who's much younger. They come in, their heart rate is 180, 190. It's going very, very fast. They're very nervous, right? If your heart's going 190 beats a minute, you're nervous. So they're coming in, their heart rate's really fast. So we need to flip it back into sinus rhythm. And we can do this with this medication. A lot of the other medications take a long time to work and don't, work immediately. This should work immediately. This is another one of these drugs that's approved by the American Heart Association for advanced cardiac life support. If you call the medics, the paramedics, and your heart rate is going 190 and you're in supraventricular tachycardia, they will give you adenosine. There's not like multiple options. They give you adenosine. So to give adenosine, we have to give it very, very, very fast. Its half-life is less than 10 seconds. So if it does not reach your heart in 10 seconds, it wears off. So that means you have to have a very, very good IV in your patient, typically in the crook of the arm, the antecubital space or higher. I think almost always in the antecubital space or higher. And you push that medication and then you slam sodium chloride flush behind it. You have to get that medication to the heart as fast as you possibly can. Well, after that happens, so that's supraventricular tachycardia on the left, we get this period of asystole. So there's flatline, right? So you get supraventricular tachycardia, you slam that medication in, antecubital space or higher, because it needs to go in really, 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 really fast, because it has a half-life of 10 seconds. So we push that medication in really fast, and then you're gonna see this period of no heartbeat. It scares the crap out of you. But after a few seconds, it's gonna come back into our normal sinus rhythm. So that's why this meme says, have you tried turning it on and off again? All right, a patient has received an IV dose of adenosine and almost immediately the heart monitor shows asystole. What should the nurse do next? So are we gonna check the patient's pulse, prepare to administer CPR, set up for defibrillation, or continue to monitor the patient? We're gonna continue to monitor the patient. So this is an expected finding. If after 5 to 10 seconds you're not getting a heart rate, then you would need to start CPR. When you're giving this to your patient, they will be on a cardiac monitor. And that is chapter 25.